Starting with the fourth part of the ART series, we'll be coming to the community field studies. The ART approach was pioneered in Tanzania in the mid 1980s, which was followed by several community field trials conducted in Thailand, Zimbabwe, and Pakistan in 1991, 1993, and 1995 respectively. Results of the studies in Thailand and Zimbabwe have shown that 71% and 85% of the ART restoration remained in the teeth after 3 years. Studies conducted in several countries showed high survival rates of atraumatic restorative material as compared to amalgam. In amalgam, it was 7 years. In glass ionomer cements, it was 5 years. Atraumatic restorative treatment is currently used in 25 countries and is part of the regular training programs for oral personnel in at least 3 countries. In a meta-analysis of 5 ART effectiveness studies, the retention of ART restorations were compared to those using a conventional method in single surface restorations and permanent dentition with a follow-up of 2 to 3 years. Only one study found that survival rate of amalgams was significantly higher than ART. The 4 other studies found that the difference in survival in the two techniques were not statistically different. The study with the longest follow-up followed 152 school children for 6 years who received either ART or conventional restorations. The survival rate in ART treated surfaces after 6 years was 68.6% compared to 74.5% in conventionally treated surfaces. This difference was not statistically significant. In clinical trials of ART compared to the traditional treatment conducted by the Pan American Health Organization in 3 South American countries, the odds of failure for ART was 1.75 times the odds of failure in amalgam or composites adjusting for the age, sex, and country. One study that was done by Steele et al. Looked at ART versus conventional restoration in the elderly with a mean age of 78.6 years, mostly with one surface caries. After 12 months, there were no statistical difference between the two types of restoration and survival rates. Systematic review and McIntosh et al. Concluded that ART can be used in both primary and permanent dentition. Survival rates of restorations using ART vary depending upon several factors. In a meta-analysis of studies reporting survival rates of ART restorations, single surface restorations were found to be more successful than multi-surface restorations in both primary and permanent dentition. High viscosity glass ionomer was retained longer than medium viscosity. In a study in Kenya of 804 children 6 to 8 years old, overall survival was 44.8% after 1 year. Survival was highest if the cavities restored were 2 to 3 mm. Frenikin et al.'s Zimbabwe study in children over 3 years found that experienced operators placed better, longer-lasting ART restoration than inexperienced ones. One surface survival rates were 88.3% in this study. Survival rates differ greatly between studies, but rates are hard to compare because the populations differ so greatly. A clinical field trial of 12 to 17-year-old Cambodian high school students found that 1 year, 76.3% of restorations were still successful and 57.9% were successful at 3 years. 118 children aged between 5 to 18 years old in Mexico were given sealants and/or restorations using ART. After 2 years, 66% of the restorations were retained. Low et al. Reported a 6-year follow-up of ART in China, concluding that smaller ART restorations survived longer than larger restorations. Overall, cavity restored using ART appeared to be as effective as conventional methods. Most studies report that there is no significant difference between the two methods. ART in the public surfaces. The first report that described the use of ART approach in a public service system originated from South Africa. ART was introduced there mainly because of its appropriate economical and restorative advantages, because of its patient friendliness. The adoption of ART was associated with training, research, and follow-up supervision. Since then, the ART approach has been proposed in several countries. The Mexican experience of incorporating ART into the public service stands out as a good example. It started with an ART course in 1998, followed by the development and acceptance of a national oral health program, including ART, and subsequently in 2002, a second ART course, after which the program could commence fully. It was estimated that 2 million ART procedures were performed in the first 6 years of the program, an increase of 400% from the baseline, and that 810 dentists had been trained in ART. The success of the restoration in primary and permanent teeth was 82% after 1 year. According to the 9 chief dental officers of 10 Latin American countries, ART has been introduced into the country's public oral health service systems, but the implementation is still in its infancy. The implementation of ART in the public health services has also been researched in Tanzania. ART introduction resulted in an increase in the mean percentage of total restorations in relation to the total treatment rendered from 3.9% at baseline to 13% at the end of the 31-month study period. The experiences in South Africa, Mexico, Tanzania, the Latin American countries, and Cambodia show that proper implementation of the ART in public oral health services is mainly hampered by two factors: the availability of ART instruments and the availability of quality glass ionomers. The strategies for successful incorporation of ART into the public oral health services should include the organization of training courses in ART, regular complete ART courses in countries, and support for course participants through ensuring the constant supply of quality high viscosity glass ionomer restorative materials. Atraumatic restorative materials for a disadvantaged Brazilian community. Training oral health personnel in October 2001 were included in the family health program in this area. These team and other dentists in public health network were trained by a university teacher in the area to perform ART restorations using glass ionomer cement. As you can see in the pictures, in South Africa, 12 play refugees in the Liberian refugee camp were trained in basic oral health care, including ART according to WHO training module. This primary oral health program for refugees were revisited after 3 years in December 1999. The 12 trained refugees maintained an oral health care clinic in the camp where patients were treated with ART. The same was done in Sri Lanka as well. In Turkey, dentists and often dental students visit the rural areas including Baghivar, a small town, and Antolia. ART restorations are performed on school children, farm workers children living in tents, or children working in cotton fields. Conclusion: Traumatic restorative treatment is a minimally invasive approach to both preventive dental caries lesions and stop its further progression. It consists of two components: sealing of caries-prone pits and fissures, and restoration of cavitated dentin lesions with sealant restorations. ART is sometimes criticized because it is being seen merely as a restorative treatment performed by dentists, but it is not only a restorative but also a preventive and a palliative treatment that is performed not only by dentists but also other operating dental personnel such as dental therapists, and it can be performed by persons without any dental education background if given proper training. For example, barefoot doctors are farmers who receive minimal basic medical and paramedical training and worked in rural villages in the People's Republic of China. Their purpose was to bring healthcare to rural areas where urban trained doctors would not settle. This increases the chance for better rural health in underserved communities in both developed and developing countries. These are my references.